doing well. And the thread comes out of it. Like general surgery, then it was very simple to arrange for him. Lymph node dissection will still strictly follow the dissection method of general surgery. It kind of looks like an open-ended perspective. It's actually that big. It has a very good viewing angle. The single-hole viewing angle is particularly good. Very good. Kind of like this one-hole view of the lung, similar to open. Right. That's the point. So incisions are important. The incision is around here. If you look at those colleagues in general surgery, his pancreas often gets in the way. Our pancreas doesn't block much. It's in the low position and it's going to take a device to press the pancreas down. Yes, press. We basically don't have much pressure on the pancreas. Of course, the pancreas will be slightly smaller. No chronic pancreatitis. That's also true. The pancreas and the blood vessels. Think of the stomach as the root of the mesentery. Think of the esophagus as two sections. It's just the upper part of the esophagus. Its roots. It also has a mesentery. The root is on the side of adding a 101, 106. So here. Mesangial root of stomach. It is also the mesangial root of the lower esophagus that must be clean. These connective tissues. That's along the surface of the pancreas. Director Lu. Director Wang. Your lung surgery is amazing. That lung surgery. The pulmonary artery is probably the hardest part. The risk of abdominal vessels like this is very low. There are many small blood vessels that easily sip blood. So the one I just talked about, coagulation aspirator. As long as there is a small bleeding assistant, it will coagulate immediately. That way the field of view can be maintained. Yes. You see, from the top down. Basically no gauze. General surgery has a piece of gauze next to it. Be sure to put a piece of dip in it. Exactly. That's basically the coagulation aspirator. It can not only pull. Then this is called ATA or 8. Intragastric common hepatic artery disc. There was a guideline for thoracic surgery. Expert consensus. The abdomen should also clear several groups of lymph nodes. ATA should be clean. It is true that the transfer rate is very low. If you move here, that means it's relatively late. But routinely, it goes from here to the proper hepatic artery. We'll stop there. The back anus is not clear. That place is picked up along the artery. The single hole is relatively smooth in one direction from left to right. Then this lymph node should be an 8 lymph node. Sometimes it's clear. Finally cleared to the portal vein. From this perspective, you don't rely much on assistance. The assistant takes the aspirator and blocks the pancreas below. But it doesn't actually depend too much on his. It's important when it comes to bleeding. Because you can't. Grabbing gauze is a waste of time. Because of a good perspective, it is good to rely on the assistant. I currently look. Dependency is still very low. His ability to expose pull is not very high. Because when doing ordinary laparoscopic dissociation, the assistant still requires him to have experience. He's going to press, pull there, block or something. He has a lot to do. Exactly. Just hold on. Like that, Professor Wang Ming. There are several videos uploaded. It's called The Wild. It seems to be Professor Wang. Yeah, I was the wild one, kind of like him. They're going to hold on tight. Assistance matter. Then go down to the lymph nodes of 8. That one is also cleaned sometimes. This is for thoracic surgeons. This kind of dissociation is irregular. The scope of doing is a little more standardized. Clean a few more lymph nodes and soften them. In this way, colleagues in general surgery will feel very formal. A little bit laggy. I feel like both sides look clear. Centered on the pancreas. Because what you just asked is very right. The incision is very important. It just fits the upper pancreas. Just these few blood vessels in the upper pancreas. It's actually in embryology. This is the root of the mesentery. Because the esophagus and the foregut of the stomach, it's mesenteric roots. Here, if you make the usual incision, the observation hole will be near the umbilical area. He can either see ahead or see behind. Right. Left to right. Looking from right to left. They look from the bottom up. Yeah, so something like that. Where is the incision location? The incision is located between the xiphoid process and the umbilical cord, about 3 or 4 centimeters, a little bit higher. Directly, for example, divide the distance between the xiphoid process and the umbilical cord into 4 equal parts. Where is it? 4. It should be about a centimeter higher. About 1.8 like this. A little higher, not necessarily. 5 equal parts 2/5 like this. Up 2 down 3 like this. Yeah, 5 equal parts is more reasonable. Then the place you just talked about, he has a very good perspective. Not so much because of that. Give people Amway single hole strongly. He didn't put a drain. Not completely single hole in the end. Professor Tang Hua from Shanghai Changzheng Hospital. He has also been doing single holes for a long time. The patient is a little mutated. The two arteries are joined together. The right gastric artery and the left gastric artery are both here. They all come from here. The left gastric vein can be burned directly with an ultrasonic knife or clip it. Then just clamp the artery here a few times. The plane behind the stomach. They call it the angel plane. Because it's easier. Basically he is like the mesentery, it passes easily. Treat the left gastric artery. Nothing else needs to be dealt with. Nudity of the left side of the stomach to the viewing angle. It's very convenient and intuitive. I feel a lot of times. Especially when viewed from the bottom up. Only free 3/4. The last side has never been able to. There's always one side of it that you can't see. There is always one side that cannot be seen clearly. There it is with the mesentery and the splenic artery. These relationships can be seen very clearly. You'll see it clearly later this time. If there is bleeding, please deal with it in time. Change a piece of gauze in it sometimes. Sometimes I don't change it. Ha ha ha, I saw it too. The main cardia should be disconnected. If the cardia is not broken, it is not easy to do when doing the spleen door later. I also seriously watched that last time. Director Yi Fan did it. He's also amputating his esophagus. After he severed this part in the chest, he pulled that one off. Same thing. You go down like this. Yes, yes, yes. When doing the spleen. Yes, yes. The plane is very loose. What they do? Right, it'll be over in about a minute or two. That place should be close to the diaphragmatic foot. The division between hard and soft parts is very clear, especially when inflated. A mesenteric relationship. Much like how they do mesentery. A section of the splenic artery is buried in the pancreas. And then actually here. Surgery digs deeper here. Splenic veins are sometimes seen. This deeper case did not deliberately expose the splenic vein, especially in this deeper case. Sometimes splenic veins can also be seen when shallow. The splenic artery, according to that consensus, about a little more than halfway through, clean more than half. The plane is very clear. Stick to the diaphragm foot and go over here. It can be easily passed to the other side. The esophagus is better free, just a little reminder. Then the splenic artery can. You can also do spleen cleaning after taking some time, but it's not necessary. Basically, the esophagus does not transfer to the spleen. Free the splenic artery to a certain point. It's almost like putting it outside the mesangium. Still attached to the artery, and then there's the lower esophagus, which is more exposed. Make use of the incision. Not only did the esophagus but also the cardia. That one has a single hole plus one. And then there's something called a hiatal hernia. Hiatal hernia uses an incision. In fact, that one is also very good. In the case of hiatal hernia, it is completely single hole. I think incisions can be generalized. Then do a single hole plus one. Where do you add it for what purpose? Add to the left side flat with the incision. Then that place is mainly. Don't you want to replace that nail seat? Or when changing the nail holder? Change the nail holder to the esophagus. And I'll pop it in from there. Take a Hemalock pliers and clip the nail holder. Put it in. As long as you stick to the diaphragmatic foot, you can find the direction. Not only can it be cleaned clearly, just the diaphragm foot is a little shaped like this. It's easy to free the lower esophagus. If it is not a double single hole through the chest, routine transthoracic warts are severed in the chest because of the double single hole. So I severed the blood vessel in the abdomen. The one that was severed in the chest. But it's the lower esophagus that's severed. Yes, right there. He just sticks to the red rich corners. Naturally fine. It's standard practice for a thoracic surgeon. Just saying that I think if it spreads, there will be more and more ways to take, and people will definitely do better than me. Relatively easy. Simplify complexity. Start here at the spleen. It used to be the free method of general surgery. It is the so-called big band side to do it very tired. Met a fat man with a long stomach. You won't get tired of doing this now. You just got to the point. Not tired at all. Esophageal surgery is less tiring. Even say. Like the last time, Director Yi did it really fast. I watched him for an hour and a half. You need to study hard in that video department. I have learned it all. Director Yi, by the way, our hospital is famous for its fast knives. Thank you very much, Director Wang. Make these videos especially good. Director Wang also said that. I remember it well too. Really must learn through video. You can learn a lot. The young doctors here are also making great progress. I have learned a lot through these videos. The spleen is particularly easy to do. We can actually clean it under the splenic artery. You can also do spleen cleaning. Exposure is very good now. The curvature of the entire splenic artery is very distinct, very beautiful. You can do a little bit more on the spleen here. You can scan it when you go down to the colon and spleen area. It's good to keep a little more fat. It's good for the blood supply to the stomach. Then take it out and fix it. Because of the incision, some more can be made, so probably do a few. As long as you do it, the left omentum can be pulled out and done. It's very simple. Pay attention to the adhesion. Then last time, Director Yi also talked about the damage to the spleen. The spleen would have been scratched open in the past. They call it the sin ligament, right? Now it's basically like this, you can see it very clearly. It is also clear in the later inspection. Just burn a few. Once it's loose, it's easy to take it out. Take it out and you can fix the looser place. Director Chiu said that they also robbed a director's schedule. Ha ha ha. I'm so sorry. Your double single-hole minimally invasive. At the moment, I think it's the most minimally invasive procedure. Can you tell me for yourself how rare this opportunity is? Because of its own operation, especially the abdomen. It's basically no learning curve. Because we had abdominal endoscopes, like you said, the 5 holes do a lot. Discovered really good. I think it should be through Director Wang's platform. Promote it to everyone well. Everyone benefits. Basic surgery like you just said, usually within 3 hours. The chest cavity is usually like this in 3 hours. I talk too much. These bags are very beautiful and very clean. Then place. This place deliberately left a little bit for fear of air leakage. Then go back and figure it out again. Director Chiu, they did it quickly and well. The two of them are doing it very quickly here. so in a very low place. Sometimes they meet in the cardia, so I deliberately left a little bit, otherwise, the anger will rush to the top. How do the chief and assistant stand? Someone in the group is asking. I stand on the right, the assistant stands on the left, then stand a little below my right with the mirror hand. It's easy not to diverge. The mirror hand is on the right-hand side of the main knife. Then take it out and fix it later. These are sometimes between the right and the left of the omentum. Some professors in Japan will bring it up inadvertently. Some very detailed communication. So it still won't be so sticky. Do it closer to the colon. Leave a little more omentum, take it out and repair it slowly. Try to preserve the blood supply. I think if the anastomosis leaks or not. The most important factors are tension and blood supply. What about other production methods? Anastomosis is secondary. His blood supply is sometimes innate. Some of them are connected. Some are unconnected. Take it out and fix it carefully. I used to want to do it with fluorescence. See how the blood supply is. Didn't stick to it later. That's too much trouble. There was a little bit of fat left at first. It should be useful to put it next to the anastomosis. But then that is sometimes done and sometimes not done. Shooting now or hand fit? I always shoot. T-shaped anastomosis. Trapezoidal. It's sort of like the left colon. It went through a lot at the beginning. And then we did it by hand. It was later found to be much narrower after the T anastomosis. Use a condom. Right. This way the stomach will not circulate. Then protect it too. This way. Director Miao of the department also graduated from Director 2. Yeah, students. He is now doing esophagus. Also get a condom to protect it. It is filled with paraffin oil, which is smooth. Yeah, hand it up. Exactly. I also put it full of paraffin oil. The funny one. Then actually I think this one hole is enough. It's not really that big. Then there is a condom to protect it. Abdominal condoms are also less susceptible to infection. Then apply a film. I feel my abdomen is a little more refreshing. And then you can actually do a jejunostomy. The jejunostomy requires an additional small opening. Look under the laparoscopy for the truce ligament. It's easy to find. And then a jejunostomy is done underneath this mouth as well. A lot of general surgery is done under the endoscope. It's worth learning from. Then take it out of the neck. If you took it out just now. Director Chiu introduced. The esophagus is more important. I've been following this lately. The regularity of lymph node metastasis. So the right recurrent laryngeal paranormal lymph node. I think it should be esophagus. It's like two pieces of intestine. The desegment bowel is in the middle and upper part. The middle and upper esophagus is equivalent to a section of intestines. The lower esophagus is equivalent to a section of the intestine. Then its mesangial. Mesangial is irregular. Call it the typical mesangial and the atypical mesangial. The mesentery and jejunum of the small intestine. The mesentery of the colon is typical. The mesentery lining of the esophagus is atypical. So these lymph nodes are hidden in the atypical lymph nodes, but it grows the upper mesentery root. It's in the inferior mesenteric artery, so above the inferior mesenteric artery. The 101 and 106 lymph nodes separated by it are key lymph nodes dissected. Those 104 nodes are also sort of the lymph nodes at the root of the mesentery. Then if an operation like this doesn't clear 104, after surgery, the patient must have a color Doppler every 3 months. Follow-up is very important. Once the lymph nodes are found to be swollen, and then do remedial lymph node dissection. 104 so follow up now. Because it only costs a few $dozen to do a color ultrasound, but it can save a patient's life. Because of early detection of 104 lymphadenopathy. Specifically, McEwen did not do SANO. 104 is not clear. It is very important. And lymph node color ultrasound can be done at the grassroots level. Then he can compare himself. This time it is 0.8, and next time it becomes 1.0. He'll come to the doctor. Triangular anastomosis, break the back one first. Just shoot with 2 guns. It was useless at first, because there are too many patients with stenosis. I think it's about the same. Missing rate is about the same, but the stenosis rate is now basically no stenosis. I first started because I was making colon straps. I had a patient with a really thick colon, and as a result, the esophagus is very small. And then I looked in the literature. It turned out that many colon-to-colon anastomosis are trapezoidal anastomosis. So it's all the one with the gun. So use the method. Fix the back wall with a few stitches first. Then these 2 holes. If the lesion is here, the upper esophagus, esophageal cancer still requires a bit of length. Someone asked in the bullet comment area, will the non-breaking of odd vein arch affect anastomotic healing? Odd vein arch. I have asked a lot of people about the strange vein bow, including when I went to Japan. The Japanese keep the odd vein arch and bronchial artery. He spends a lot of time preserving. So I asked him, why can't the strange vein bow be severed? Why didn't the strange vein bow break? He faltered. What about liver cirrhosis? It affects liver function. Yes, what will break the end and form a blood clot? I don't think I've ever come across one. If you do a regular odd vein, it will be severed. The most important thing is when making lungs. When doing minimally invasive lung surgery early, 20 right lymph nodes were dissected. Routine amputation of odd venous arch during lung surgery. That's very easy to use. And I have to. For things I've given lectures, specially mobilize everyone to break the strange vein bow, to dissect groups 2 and 4 lymph nodes. And young people, of course, are very skilled. I think you can save at least 10 minutes. So I looked at so many odd venous arches. There were never any complications. There's no clots. So I now boldly advocate cutting off the strange vein bow. If it's okay, just cut it off, particularly the lymph nodes. Especially when there are large lymph nodes. I think it should be routinely disconnected. Director Wang can also try it. Make an appeal, especially the sleeve on the upper right under the endoscope. Sleeve. Severe vein arch. Someone's going to pull it away. It often affects that suspension head. And I saw the video that day. Which director is it? He's doing just fine. So I think it's okay to break the strange vein bow, including bronchial arteries. But mediastinoscopy can't help it. But it can't be done. The strange artery bled when it was touched. That's still reserved. So the bullet comment section asked. He actually felt that everyone was disconnected. Mediastinoscopy can't separate the odd venous arch. Will the strange vein bow get stuck there like a buckle? Cause poor blood supply or other conditions? But it doesn't. This part off. Because the tubular stomach is small. And the Japanese, he never leaves. Not everyone. Not everyone, but the Japanese, he is after the sternum, post-sternum. They cut off the upper and lower esophagus for the sternum. The anastomosis is really simple to make. I was stuck once. It's not a mediastinoscope.